Hello there and welcome to the 2021 class presentation from Conway. My name's Martin Conway, I'm Head of Professional Services at Conway and I'll be leading you through this presentation. We decided to take a look back at the development of the Optimum Infinite material that's now been on the market for 3 years. So I thought I'd take you through both the development process and also look at some clinical experience using colleagues from both Conway and from outside of Conway, some independent practitioners. So first of all, we'll have a look at the development process. By 2016, it was clear that scleral lenses and ortho-K were not really going to stay just the province of the specialist practitioner. They were gaining traction, and ever since 2000, the year 2000, more and more publications had taken place looking at the use of these modalities in general practice, both for irregular corneas in the case of sclerals and for the management of myopia in children with ortho-K. So if we look here at these two graphs, we can see that scleral publications really took off at around about 2004. The numbers of papers published regarding the use of scleral lenses, you can see from the graph. And again with ortho-K, we can see that since the year 2000, the intensity of publications and awareness of ortho-K as a modality to control myopia. Those green lines on the graphs, incidentally, mark the point of 2004. And most of the current materials used in both sclerals and ortho-K were in fact developed and marketed before that period, so before massive interest in sclerals and ortho-K occurred. If we look at a typical RGP material, here's an RGP on an eye, we can see that a contact lens made of an RGP material is normally about 0.15 to 0.2 millimeter center thickness. In typical use, it would cover about 65% of the corneal surface, and about 20% of the tears underneath that lens would be exchanged with each blink. So we have two mechanisms, well, three mechanisms really, for getting oxygen to the cornea. We have 1/3 of the corneal surface exposed to atmospheric oxygen as per normal. We have 65% of the corneal surface covered by a contact lens of just 0.15 to 0.2 or 150 to 200 microns center thickness. And we also have 20% of that corneal tear layer exchange with every blink. So we have three mechanisms bringing oxygen to the cornea underneath the lens. If we now look at a scleral lens on the eye, first of all, we've doubled the thickness of the material. We're now looking at a lens of 300 microns thickness minimum, which has halved the available oxygen to the cornea underneath it. We've now got 100% corneal coverage, and so we lose any atmospheric oxygen advantage that was present with the corneal lens. And we've also lost our tear exchange. So we've lost two essential methods of bringing oxygen to the cornea, and at the same time we've reduced the effectivity of the oxygen through the material by 50%. With ortho-K, we have an added disadvantage that the lens is used on eye underneath the closed lid, and so thus reducing the availability of oxygen through the lens to the cornea. More importantly, these lenses are normally used on children's eyes. So we really realized that it was time that we looked at available materials to see exactly what was on the market and what was needed to improve the oxygen performance of the materials that were currently in use, with these two modalities in mind in particular. The challenge for us really was to develop a material that both maintained high oxygen permeability and high flexural modulus. In other words, the lens remained rigid during wear. In both modalities, both for scleral and ortho-K, it's essential that the lens maintains its shape during the wear. A difficult challenge, and I'll hand you over now to my colleague Dr. Mark Edelston, who was presented with this challenge in order to develop the material.
Okay, so we knew that this combination of high modulus and high decay was going to be ideal for both scleral and ortho-K modalities. The question we asked at Contomac was, were there any existing RGP materials which already had this combination of properties? So this graph shows data for common RGP materials, which we've collected in-house at Contomac. It's not important which materials which, it's really just looking at general trends here. And what I've done is I've plotted oxygen permeability or decay in barras on the horizontal axis, and I've plotted flexural modulus in megapascals on the vertical axis. And the area we're interested in for both scleral and ortho-K lenses is this top right corner where we have the combination of hyperdecay and high modulus. And what we can see from the graph is that there were very, very few materials which actually fitted into this region. It's not a very highly populated region on the graph. Majority of the materials sort of run in a path from top left to bottom right. And I'll come back to this later. So this slide shows a chemical structure, and it's a chemical structure of a molecule called tris. And tris is added to almost all RGP materials, and it's added to these materials in order to impart oxygen permeability. But it's not the only way we can introduce oxygen permeability into a contact lens material. This second chemical structure is another molecule called styryle tris, and it shares many of the same characteristics as tris does. So they both have a carbon-to-carbon double bond in the molecule, and this is a point where we can perform a polymerization reaction and join molecules together into long polymer chains. Polymerization turns either tris or styryle tris, which are both liquids, into a rigid plastic which is suitable for use in a contact lens. This is usually done in combination with several other polymerizable ingredients. These molecules both also have a siloxane group, sort of shown at the bottom. And these groups bring oxygen permeability due to the presence of chemical bonds between silicon and oxygen atoms. And these bonds just happen to provide enough space for oxygen molecules to pass by, hence the oxygen permeability. So these two molecules are very similar at the top and the bottom, but they're very different in the middle. So in the middle region in tris, we have a series of bonds between carbon and oxygen atoms, and each of these bonds can rotate, and that makes the tris molecule flexible. In contrast with styryle tris, the linking group between the top and the bottom parts of the molecule is a benzene ring, which is a very rigid group, and this brings rigidity to the styryle tris molecule. Importantly, these differences in molecular properties also transfer to material properties when these two species are polymerized into a contact lens plastic. So we can see a difference in rigidity between materials made with tris and made with styryle tris. So when we tried making some formulations where we did exactly that, we replaced tris with styryle tris, we were able to make materials which had the combination of hyperdecay and high modulus and start to populate this top right corner of the graph where we know that materials are ideal for both scleral and ortho-K modalities. And I'll hand back over to Martin now.
Apart from the obvious technical and chemistry problems to be overcome with the development of a new hyperdecay, was how these types of materials are viewed by practitioners and the laboratories generally. Generally, we have negative associations associated with poor latherability, poor scratch resistance, and poor wettability. This is even taught in optometry and contact lens courses. And in fact, in a recent publication in Contact Lenses and Anterior Eye, several key opinion leaders discussing this topic stated that high decay materials are less scratch resistant and therefore may require more frequent replacement. Now this is a myth that we had to overcome, and I'll hand over back now to Mark to explain exactly how we overcame this.
So at Contomac, we looked at these negative associations between hyperdecay materials and undesirable characteristics in more detail. So this graph shows oxygen permeability and hardness data for common RGP materials. Again, this is data we've collected in-house at Contomac. And what we can see is that as the oxygen permeability of a material increases, there tends to be a corresponding decrease in hardness. And because hardness correlates well with other properties such as scratch resistance and latherability, we can see why maybe a hyperdecay material might not behave optimally when it's made into a contact lens. Each of the materials shown on this graph contain tris to impart oxygen permeability, So as the tris content increases, the oxygen permeability tends to increase. But because tris is a flexible, floppy molecule, this comes at the cost of a lower hardness. But what about sterile tris? With sterile tris, we can start to break this link between hyperdecay and low hardness. Going to sterile tris, we can generate materials which are several hardness units harder than a tris-based material of the same oxygen permeability. So for example, at 180 dK, we might expect that a tris-based molecule would have a hardness of about 74 Shor-D units, whereas with sterile tris, a sterile tris-based material may have a hardness of around 81 Shor-D units. And in terms of material properties, material behavior, this is an enormous difference. Sterile tris does come with one disadvantage. The key disadvantage with sterile tris is cost. It's several times more expensive to make than tris is, but because of the beneficial properties that sterile tris brings to a material, we decided to go ahead and use it anyway with the development of Optimum Infinite. So with our development of Infinite, our aim was to prepare the first ever RGP material which was specifically optimized for use in scleral and ortho-K modalities. So we knew it had to have the combination of hyperdecay and high modulus. But it became clear to us that in order to be sort of well accepted on the market, it would also have to have a very, very good balance of properties. So we started focusing our attention on formulations which also brought good wettability, hardness, latherability, and in particular scratch resistance. So you wouldn't believe the number of hours I spent in the lab sort of rubbing lenses over and over and over again just to ensure that the scratch resistance matched that of other leading materials. So after several years of development and literally hundreds of formulations that we have investigated, we came up with a set of formulations which really gave us honed in on the hyperdecay, the high modulus, and also gave this a great balance of properties. And that through those formulations, Optimum Infinite was born.
Having overcome the technical problems of developing such a material, the Optimum Infinite was actually launched in 2019. It's now a well-established product, initially in scleral lenses, but more recently it's been adopted for use in ortho-K designs by many practitioners. And one lab in the United States so far has achieved FDA approval for its use in that modality. The product has been generally well received by practitioners, and customers have complimented us on its scratch resistance as well as its innate wettability. And in a study at Aston University in 2020, in comparison with other low decay materials, it scored greater comfort than other materials in the trial. So I think we're now at a point where we are overcoming that old myth that hyperdecay materials were both dry and scratchable. Let's not just take my word for it. I'd now like to introduce a well-known face in the optometric community, Greg Denier from Ohio in the US. And Greg's going to take us through a couple of cases that he has used Optimum Infinite successfully in.
Hi, my name is Dr. Greg Denier, and today I'd like to share with you some cases, some scleral lens cases to manage dry eye disease using Optimum Infinite material. The first case that I want to present today is a patient who is a 74-year-old female patient with Sjogren's syndrome. She has symptoms of irritation, burning, and tearing. You can see from the photograph that she has severe punctate keratopathy in both eyes. When she came to our practice, when she came to see me, she was already on maximum medical therapy and palliative treatment, including warm compresses, punctal plugs, artificial tears, Restasis, and autologous serum. Yet, despite all that, she's still very symptomatic. So we recommended scleral contact lenses for her. In my practice, when we fit a patient with scleral contact lenses, we measure their eye with corneal scleral topography, and we use those measurements to create a three-dimensional model that we then use for lens design. So that's what we did for this patient. We were able to design 16.5 millimeter free-form scleral contact lenses using Optimum Infinite material. And For this patient, because of her known and severe dryness, we did add HydraPEG surface treatment to improve wettability and comfort of the contact lenses. With her manufactured contact lenses after dispense, she was able to see 20/25 vision in both her right and left eyes. Overnight, she cleaned and disinfected the contact lenses with hydrogen peroxide care system, and prior to application, she does fill her scleral lenses with 0.9% sodium chloride saline solution. This patient reported significantly improved comfort and relief with her scleral contact lenses. The optimum infinite material with HydraPEG surface treatment allowed for a wettable surface that maximized oxygen or transmissibility. Her corneas remain healthy without edema or neovascularization. The next case is a patient who had bilateral full-thickness corneal transplants and also has dry eye disease. Since her transplant, she has a history of corneal irregularity, high astigmatism, meibomian gland dysfunction, dry eye disease, and filamentary keratitis of her left eye. She also has diplopia, uncorrected, secondary to a left hypertropia. Her current treatment when she reported to our office was just wearing glasses with prism. She was doing lid scrubs and artificial tears. This is her spectacle correction, and you can see that she has a high amount of toricity of corneal astigmatism. She's only able to achieve 20/30 vision in her right eye and 20/70 in her left eye, and she does have prism in her glasses to correct for her double vision. She has full thickness transplants that were examined under microscopy. Her right eye is without sutures, and her left eye still had some interrupted sutures. We did recommend scleral contact lenses for her. We fit these as freeform custom lenses from corneal scleral topography. For her right eye, she had a 16.5 millimeter lens manufactured with optimum infinite material. With a plus 175 power, she was able to see 20/25. And then in her left eye, same diameter, using optimum infinite material with plus 8, she was able to improve down to 20/20 vision. However, the patient did report, as I think we might expect, some double vision with her scleral contact lenses, and there was a very minor overrefraction. We did remanufacture her contact lenses. We added some prism that we had previously demonstrated over her contact lenses. So this included one prism diopter base up in her right eye and one prism diopter base down in her left eye. And with the new powers and the prism, she was able to see quite well 20/25 in the right, 20/20 in the left, and the prism corrected her double vision. Overnight, she cleans and disinfects contact lenses with hydrogen peroxide care systems and fills her lens with 0.9% sodium chloride solution. For a patient with corneal transplant, it is critical that we fit a scleral contact lens using a hyperpermeable gas perm lens material that maximizes oxygen. Patients with corneal full thickness corneal transplants are at greater risk for neovascularization or corneal edema because they often have reduced endothelial cell counts. And when we put a scleral contact lens on the patient's eye, it's going to create a hypoxic stress. So for this patient, the infinite material successfully prevented corneal edema and neovascularization, and she's very successful with her scleral contact lenses. And the last patient is a 40-year-old male patient with granular lattice dystrophy. His symptoms, upon reporting to me in our office, he had decreased visual acuity, dry eye, and significant light sensitivity. He was using artificial tears. He didn't have glasses or contact lenses. His uncorrected visual acuity was 20/50 in both right and left eyes. And examination showed moderate granular lattice changes in dry eye. Well, I mean, his options are you could have a full thickness corneal transplant or be fit with scleral contact lenses. we all decided, including the cornea specialist, patient, myself, to try scleral contact lenses. We did fit him with freeform customized scleral lenses from Corneal Scleral Topography, manufactured with optimum infinite material. His first initial pair, he did quite well, 20/50 in the right eye, 20/40 in the left eye. He did have a minor over-refraction, and the fluid reservoir of these contact lenses was minimal. So we did remake his lenses, adding the over-refraction, which improved his visual acuity to 20/40 in the right eye and 20/20 in the left eye. We increased the sag for better or increased fluid reservoir between the contact lens and his cornea. And here are his fit scleral contact lenses. He did quite well with these lenses and continues to do well. The lenses now have adequate fluid reservoir and alignment of the landing zone. The infinite material provides excellent wetting and maximum transmissibility. Thank you.
I'd like to thank Greg for his contribution, and now take us over to Hans Bleschoy from Denmark, another practitioner using Infinite for some years now. He's taken a slightly different approach. He's going to explain how Optimum Infinite helped him overcome difficulties with patients using different materials.
Hi, my name is Hans Bleschoy. I have been working with RGP lenses for many years now. Nowadays I only use exclusively high DK materials, and I have a couple of cases that I would like to share with you, and I hope you will enjoy them and learn from the experience that I have had with these materials. The first case I have is a male. He's 21 years old now. He was originally 18 when he came to our practice 3 years ago. The reason for coming to us was that he was taking his driving license, and at that medical examination they actually discovered that his left eye had poor vision. He's now 21, so we've been following him for 3 years. He was diagnosed keratoconus. He was classic keratoconic patient, as he had a little bit of some asthmatic problems. Mainly allergy to grass pollen, but otherwise he was fit and in good health. He had been suffering from headaches for many years, and he had complained about this, but nobody really discovered the primary reason for his headaches. When he came to us originally, his right eye had unaided vision of 20/40, and his left eye was less than 2400 in the VA. We tried to do a refraction on him, but he didn't really come up in any matter. -0.25 on the right eye, still 20/40, and -0.75 with a 1 sil on the left eye, just about reaching 2400. On OCT, his corneas appeared very thin. The left one obviously a lot thinner than the right one being 496 microns, the left one 448 microns. About a year and a half ago he was cross-linked on the left eye, very successful, and that seemed to sort of have stopped the development of further progression from the keratoconic condition in his left eye. We fitted him with a 5-curved toric peripheral lens, and we used a high oxygen permeable material at the time. We used an alcohol-based cleaner, multi-purpose soaking solution, and non-preserved saline for inserting the lenses in. We had a few challenges from him because his eyes were rather deep set. So handling the lenses, both from our point of view, but especially from his own point of view, was a challenge to get the lenses inserted without getting air bubbles in. Lens cleaning, he wasn't very compliant, and that showed up in the following aftercare sessions. We had several sessions in terms of training him how to insert the lens and also remove it. We fenestrated both lenses only with the facility of removing the lenses a little bit easier than without fenestrations. We started him off with a RGP material of a DK around 100. But after a few months, 3 to 6 months, when he came for aftercare visits, the lenses really showed heavy deposits, as you can see in the picture there. We asked him about his aftercare or his cleaning of the lenses, and he was not compliant in any way. And we stressed that this was very important, that we actually got him to follow our instructions from this point of view. About a year and a half ago, we changed him to a different material with DK about 180. We stressed the cleaning regime. We stressed that it was important in order to get the comfort and the vision that he actually stuck to our instructions, and his cleaning really did improve. His vision improved dramatically, his wearing time improved dramatically, and his headaches actually had disappeared by now. His vision with the lenses in, 20/20 right and left. His wearing time was 16 hours or more, full day. And as I say, his comfort was good. Corneas are clear, no staining, no redness, and the lenses are actually wetting well. So he was a very happy patient now. So he's doing very well with RGP lenses and is now completing his A-levels. And he got his driving license. The second case I have for you is a rather complicated one. It involves a 55-year-old woman. She originally was hyperope with a little bit of astigmatism and had been using soft contact lenses quite a few years back. Not from our practice, but from somewhere else. Her lifestyle and her temperament, personality, made her choose or go for a LASIK operation in order to get rid of her dependency on spectacles and contact lenses. She was driving a motorbike and she wanted to get free of her glasses and contact lenses so she could wear her helmet and have a good visual outcome from that point of view. She was operated on about 5-6 years back. That didn't go too well, and after the 5th operation on both eyes, the surgeons actually gave up and referred her to us for RGP lens fitting. She is a complicated lady because she has general health problems, taking a lot of medications, psychological problems. She suffers from headaches. Her vision is blurred, it's unstable. She's suffering from photophobia to the degree that she's actually having to wear sunglasses both outdoors and inside the house. She can drive a car, but only in the daytime. She cannot drive at nighttime. So her everyday life is rather restricted and limited to the things, and she certainly didn't have the freedom that she was going for in the first place by going for a LASIK operation. Furthermore, she had cataract operation on her left eye and upper lid operation as well. Presenting to us her uncorrected vision was on the right eye 20/250 and on the left one 20/320 or less than that. Her right eye was hyperopic with a moderate sill, and her left eye was now myopic with a moderate sill. With the best correction, the right eye best spectacle correction, her right eye was 20/70, and on the left one 20/125. So she was not really able to wear spectacles to a degree where her vision would be satisfactory. The topography showed a flat cornea on the right eye and a rather steep one on the left eye, with highly irregular mires on both eyes. On OCT, her corneal thickness was very thin. Her right one was reduced to 389 microns on the thinnest spot, and on the left one 420 microns on the thinnest spot. Eyes on her first presentation without contact lenses or anything was irritated eyes. She was uncomfortable, her vision was unstable, it changed, refracting whatever we could refract her for was different from the morning, midday until the evening. She had red eyes and she had mucin-like secretions in both eyes that gave her irritation again generally. We tried to fit her with a 16.5 millimeter RGP lens of a DK of about 50 to 60 DK value, yeah. The lenses were clear of her cornea, so they were only supported on the conjunctiva. Her limbus was free from touch. The contact lenses were not comfortable. Her vision was still unstable, although better than with spectacles. She suffered from redness still. Her vision became more blurred after a few hours. The lenses attracted mucin-like deposits, both on the front and the back surface, and lens life was maximum 3 to 4 months before they were so deposited that we had to exchange them for new lenses. About 3 years ago, we changed her material to a DK of 100. We didn't change the design of the lens. The performance of the higher DK material was more or less the same as the original DK material of 50 to 60. Her vision was blurred after a few hours. Lens life was still short, mucin-like deposits accumulating front and the back. So all in all, it was pretty much similar to her original DK 50-60 material. Her eyes were rather uncomfortable on lens removal. A year and a half ago, 2 years ago, we changed her to a higher DK material around about 160 or more. Now that improved her comfort. Her wearing time had now increased to that of the double, 4 to 6 hours. Vision was still a little bit unstable. Her redness had improved but hadn't gone. Lens design was unchanged. Lens wetting had improved. We didn't change the solution, so the lens design and the solution, the care regime was exactly the same as the previous lenses. So the outcome here was certainly an improvement over the lower DK materials. About a year and a half ago, we changed her again to a DK material of higher DK, about 180, and that made quite a dramatic improvement. Lens comfort improved, wearing time doubled that. We're now up to about 8 to 10 hours a day. Her vision was very much better. Hardly any variability is noted during the daytime. Her redness has almost disappeared. The recurrent infections that she used to experience with any other material or without contact lenses had more or less disappeared now. She didn't use any antibiotics anymore, and she was, and her ophthalmologist was very happy from that point of view. The corneal staining that we see is mainly due to the irregular corneas and not due to any side effects from wearing the contact lenses. The contact lens wetting, the surface of the lenses, is so much better than previously. We're still seeing a few mucin droplets. We do not see the accumulation of debris between the lens and the eye, at least not as much as we used to see with the others. And the life expectancy of the material has improved to about 6 months. So the eyes are appearing much more calm, redness has gone, she looks much more comfortable with the lenses on, and she's actually achieving pretty good vision now. All in all, she's happy, I'm happy, although having said that, she's not really completely satisfied, because her original wish was to get rid of spectacles and contact lenses, and we haven't been able to solve that dilemma from her, but at least she can live a pretty normal life. Her headaches are gone. She can drive a car in the daytime and at night. She still has a little bit of photophobia from the corneal scarring, but she's living a comfortable life vision-wise now. So from her point of view, it's a successful story. Thank you very much for listening, and I hope you had some good value out of my 2 cases for you.
In conclusion, I'd like to leave you with one take-home message. We no longer have to tolerate scratchy, dry materials when thinking of hyper-decay materials. We can now prescribe scleral and ortho-K lenses using Optimum Infinite, knowing that we have a scratch-resistant, wettable, hyper-decay solution for our patients.
So for me, it's really exciting to see Optimum Infinite having a positive impact on people's contact lens journeys, and hopefully we'll be able to bring these benefits to more and more patients over the coming years. Thank you very much to Greg and to Hans for their contributions. Thank you very much for your attention. I hope you enjoyed the presentation. Thank you.